There you go. Okay. Hello, everybody. My group did virtual reality in nursing, and it was done by Mckenzie Myers, Josie Lynn, Vivian Laware, and me, Christopher Tavour. And I apologize for my coughs in advance. Okay, so virtual reality is a computer-generated experience that creates a fully simulated environment. VR lets users engage with realistic 3D environments that simulate multiple senses through computer graphics, sound, and other sensory inputs. Fully immersive virtual reality is recommended for students and because it provides the highest level of immersion, and I'll speak more about that later. So VR is used in nursing education as part of simulations that closely replicate clinical environments and scenarios. VR provides a safe environment for students to practice clinical scenarios without the fear of making mistakes. Full IVR is recommended to provide exposure to complex scenarios like emergency management or sterile techniques that they might not get to experience in the lab setting. VR integrated education programs focus on three main course categories, such as nursing techniques, which is mainly focused on PPE donning and doffing, urinary catheter placement, nasogastric tube feeding, and other scenarios related like this. They also educates disease care such as infection control training, psychiatric care, pediatric emergency care, and neonatal resuscitations, and also allows the student to implement the nursing care process such as ADPI, which is assess, diagnose, plan, implement, and evaluate. So for knowledge acquisition, VR significantly improved learning outcomes with a small effect size. The standardized mean difference, or SMD, was 0.34, and this means that VR learners were slightly better than those using traditional methods. For skills, VR had a bigger impact with an SMD of 0.72, which means a medium to large improvement in hands-on skills compared to traditional training. For problem solving, it showed the strongest effect with an SMD of 1.46, a large effect size showing that VR really helps people think critically and apply what they've learned. Finally, the fully immersive VR experience, like using a headset, which was more effective than standard education overall, with an SMD of 0.41, a small to medium effect size. All these results had p-values below 0.05, meaning that the findings are statistically significant and were not due to chance. So VR closely simulates clinical environments and scenarios for active learning, repeated practice, and getting immediate feedback without the risking patient safety. The semi-immersive virtual reality, which is also known as SIVR, technology can be used by nursing staff to simulate scenarios of anything imaginable, such as how to deal with arrhythmias, heart failure, stroke, following procedures for COVID-19, mechanical ventilations, pneumonia, as well as chronic kidney disease, acute kidney disease, and how to deal with Alzheimer's, Parkinson's, epilepsies, and strokes. So a random double-blind study conducted at the Yale University School of Medicine Department of Surgery demonstrated a significant improvement in the performance of residents who used VR for surgical simulations, and surgeons trained on VR performed 29% faster, and these surgeons made 6 times fewer errors than those trained using other methods. It also improved performance in the operating room following the VR training that was observed. So a case study was found that VR improved medical staff adherence to key patient safety and infection control procedures, and it revealed that staff usually fail to follow proper procedures when doffing PPE about 90% of the time. This is a huge risk for infection. Dr. Faruka Jafri developed a VR program at White Plains Hospital for physicians and nurses to repeatedly practice donning and doffing masks, shields, gloves, and gowns. This training reinforces the strict PPE protocol, placing staff in a virtual exam room to view tutorials, practice, and to be tested on their adherence to the procedure. The program allows repeated practice without consuming the faculty's physical and often difficult to resupply PPE supplies. So VR in healthcare requires an approach centered around sound, strong educational principles and resource planning. And our first phase of implementation would be the planning, of course. So we would need to conduct a needs analysis, set goals to identify skills and scenarios most suitable for VR training, and ensure VR is aligned with learning outcomes. Some potential barriers that we might run into would be lack of equipment, So making equipment available in designated locations for students to practice on whenever they need would be a huge support to this plan. VR should be adjusted based on individuals' physical conditions to minimize the risk of motion sickness because, of course, we're all different. And of course, continuous monitoring and evaluation are necessary to assess the technology's impact on patient outcomes and to evaluate the outcomes of our plan. So, students and staff can repeatedly practice complex procedures and experiment, which eliminates the fear of causing harms to a real patient. And a positive effect on patient safety. Evidence in studies shows that surgeons trained in via VR perform 29% faster and 6 times fewer errors, as mentioned before, which is a huge improvement. And this also enforces safety protocols, and by doing so, it reduces the spread of infection because of the practice of donning and doffing PPE. This also provides opportunity for students who may need to practice longer and obtain additional skills because we all also learn differently and at different rates. The increasing availability of VR equipment supports accessibility, so this should be something that we see more often in our future education. Here are our references, and thank you again for listening and watching this, and I hope you all have a great rest of your day. Thank you.